right, it's 12:16. It's time now for Health Facts with the Dr. Brown. Be tuned. All right, Dr. Brown.
All right, all right. Thank you for that introduction as always. And good afternoon, listeners. You're locked into WVOE, the voice of Ebony, where your health is our heartbeat. I'm your host, Dr. Christopher Brown, president and founder for PressureMDAcademy, welcoming you to another enriching session of Health Facts, the show where wisdom meets wellness and knowledge is always in season. So thank you for tuning in and listening to us, whether it's on the radio or online. We always appreciate everyone kind of chiming in to see see what information that they can glean from for the next 20, 25 minutes. Okay, so today, I know last time we talked about diabetes. I think the time before that talked about hypertension. And of course, on this show over the last years, we've pretty much focused on, different, actual health issues that are going on inside of a person's bodies. So whether it's heart issues, how to protect yourself from colds, those sort of things. Today we're going to try something a little different. And what we're going to focus on today is trying to understand, you know, uh, how to access or how to afford access to healthcare. And the reason why we kind of picking this topic is because, you know, right now, I'm sure everyone is aware of a lot of the news and politics around, getting insurance coverage and the different opinions that people have for that. And one of the things that I've experienced, yeah, both as both as an individual and as a physician, is kind of navigating insurance. Whether it's when I was working independently, I had to get my own insurance, and of course, there is something that we know as the Affordable Care Act that has an exchange that we can get our own insurance from. And then I've of course been employed, so of course, employment comes with its own insurance. And then, of course, as a physician, sometimes, whether I'm working in a hospital, work for myself, you deal with patients that have to navigate getting things covered, whether it's, like I said, your medications getting covered, or, like when people need certain devices, getting that covered. So what we're going to tap into for the next two shows is a little bit of information about insurance in general, and then, kind of different ways to access healthcare in America. And the reason I kind of broke it down into that is that, a lot of people think that if you don't have insurance, you can't get healthcare. And the truth is that, you actually can. There's something we call cash pricing. There's a special way to kind of interact with people that provide healthcare, in order to get coverage for, like say you had high blood pressure, you can actually get someone to see you and manage your high blood pressure, with actual cash. Also, in addition to regular insurances, there are other ways, they call shared health plans that allow you to get coverage. There are what we call high deductible insurances that where you can, pay a little bit more, but like I said, the insurance doesn't kick in until like a certain what they call deductible is met, but it allows you to save a lot of your money into these health savings accounts. So a lot of those things are out there, and sometimes people don't know about these. And so what we're going to do is we're going to try to, hopefully, it's a lot of information to try to get into two shows, but we're going to try and get you at least an idea of what's out there. So, of course, as always, there are a couple of disclaimers. Number one is that, anything on the show is meant as, education, entertainment. This is none of this stuff is exact medical advice. So always go to your primary for any medical advice. And then, of course, with insurance, I'm not an insurance agent. I do can get you access to what they call the shared health plan. So, like I said, if you reach out to us, we can negotiate that. We can talk about that. But I'm not an insurance agent, so this is not something I specialize in. But this is more so kind of my experiences that I'm sharing with you all, so that you can have a different view of how to get things paid for, or a different view of your insurance options that are available. So that's what this is for. Okay. So, and so we're going to get started with a little information about, actually, I'm going to talk to you a little about open enrollment because this is the season of open enrollment. Usually, November, December, depending upon your plan, that's usually the time when you can, and open enrollment is that it's a specific period each year where individuals can sign up for insurance, renew insurance, or change their insurance coverage. It's actually a very important window that a lot of people, like I said, if you got a job, of course, usually people are reminding you a lot. But if you have, whether it's Medicare or even Medicaid, or if you have some private insurance, this window becomes very important because, number one, if you don't have insurance, it allows you to go shop around and find your insurance. If you do have insurance, number one, you can renew it. So you renew it. And then number two, what's more important is that you can change your health insurance coverage. So say that you had an existing insurance product and you know what, you don't like it. Like it doesn't cover the stuff you need. Maybe the deductible's too high or you think you can make it better by being a little lower. So, you can change it during this thing called open enrollment. So it's a very important period of time. Now, the open enrollment window, and that's, when you can make this change, it is different um, for different insurances. So if you've got an employer-sponsored health insurance, whether you're getting your insurance off of the Affordable Care Act marketplace, or if you're getting it, say, out of Medicare, each one of those entities is going to have different windows where you can make these changes. Because outside of that window, a lot of times you can't access insurance or change your insurance unless there's what they call a qualifying event, and that's special things going on. So like if you lost your coverage, you got married, birth, adoptions, or you moved to a whole new place, like I said, that opens it up. But outside of that, for the most part, you can't do that. Okay. So no, so the main caveats of insurance. So, you got employer sponsored health insurance. And so, of course, if you're employed and they offer that, you can select to get enrolled in that. And those enrollment dates are set by the employer, not by the government. So, I know for one of the employers I used to work at, they used to have it seemed like it was like 4 or 6 weeks to make your decision about open enrollment. And now it seems like it's narrowed down to about 2, maybe 3 weeks. But those dates are set by by the employer. And so they can adjust it. So they can make it this, like I said, into August if they wanted to, but it's all set by them. So be aware of that. But usually they'll send you emails and reminders. But you want to make sure you know about that. Okay. And then of course Medicare. So this is what I would call traditional Medicare, and those open enrollment dates are typically, I think it's around October to December 7th. So we are kind of coming up on the end of the kind of traditional stuff. And then they have Medicare Advantage. And so one thing to know is that there's a difference between, kind of traditional Medicare. This is the government run sponsored plan. And then Medicare Advantage is where basically Medicare will kind of almost carve out a certain portion of the population or allow an insurance company, say for example, a Blue Cross Blue Shield, they can get access to the Medicare population by all these calls and stuff you get. They're trying to enroll you under their Medicare Advantage product. And they may have certain things that are a little bit different than traditional Medicare. So that's what a Medicare Advantage plan is for. And I think that those open enrollments I think it's more like January to March. But of course, you can always check and make sure that you are in the right window frame. Okay. So that's so your employer sponsored health insurance, that's the one where you have a job, your employer, your job or your employer has certain dates that they allow you to sign up for their health insurance or to change it. There's Medicare, and Medicare is for individuals that are 65 and older. So those are that's the Medicare population. And the Medicare is in two different sections. So there's what we call traditional Medicare, which is a government-run program, and then there's the Medicare Advantage, which is more of a private. It's kind of a private section of that insurance where you're going through a different insurance company. So like a Blue Cross Blue Shield, you know, Anthem, or one of these other larger insurance companies, and so they're taking over your Medicare for you. And a lot of times they'll have like maybe like some little small premium or something of that nature, but they may have some different things that they offer. Okay, and then there are the people that, you know, like I said, they're not covered under employer-sponsored health insurance, and they not old enough to qualify for Medicare, and so they now have what they call the Affordable Care Act marketplace, and that marketplace enrollment usually runs around, I think, November 1st to about around January 15th. Always double check, and during this time you can select a new plan, renew your current plan. You can actually apply for subsidies. So, like one of the things with the Affordable Care Act is that you know, if you're in a certain income, you know, the government may subsidize your insurance premium. So, like anytime you have insurance, you know, any type of insurance, there's usually a premium, and so that's the same when we're talking about health insurance. And so you'll, hey, do your application. They'll quote you a price, you know, $100, you know, $800, whatever that is. And so you can apply for subsidies if you think you might qualify, in which case it would say that your insurance is, you know, $800 a month. They may say that you qualify for, you know, $500 of that being covered by the government. So you'll pay the three, the government pays the five, and, you know, like I said, that might be what you do. So that's part of the subsidy part of that. And part of that is what, you know, like I said, I know we recently had a shutdown. Part of that issue was around whether or not the government, you know, should be providing the subsidies. One side said yes, the other side says no, and so that was part of the impasse. That was part of the impasse that was there. Okay. But that, like I said, during this enrollment period, you can compare deductibles, premiums, co-pays, provider networks. Like I said, I actually had to utilize this quite a while ago when I was doing independent contract work. And yes, so like, you know, you would sign up 1 year, you would have a price. Then the next year, you would have to go through. You had the opportunity to kind of go through and see, you know, maybe you're paying 800, and the next year there might be a product on there or insurance available that might be 500. So you might drop it. But of course, whenever the price goes up or down, you want to look and see whether or not your deductibles are different or what's going on from that standpoint. Okay. And so that's kind of a brief overview of, you know, kind of open enrollment, what that is, kind of the different types of insurances that are out there. And this becomes important because, you know, for people that don't, you know, like if you don't have a chronic disease, does it really matter? Only if you get ill within that 1 year frame. But for people that have certain conditions, so hypertension, kidney disease, diabetes, you know, you want to you want to see, you know, what your deductibles are going to be, you know, high or low. What sort of co-pays do you make? Because, you know, one insurance plan may have a copay of $20 for primary care, you know, $25 for a specialist. Whereas another insurance plan, maybe their premium is a little lower, but hey, you know, look, you know, their primary care, you know, the amount you pay, copay might be $20, but the specialist copay might be $60. And if that's the case, you got to see, you know, estimate how often are you going to see your specialist. So yet again, if you don't have a lot of conditions, you know, you may be okay. But if you have some, you know, kidney disease, heart disease, maybe you have a diabetes specialist, and you're seeing them every 3 months, remember, every time you see that specialist, it's $60 on top of everything else you're paying. And so that may become an issue for you. Now, if the difference in insurance and your premiums is enough, then it might be fine. But have to be aware of that whenever you're doing your open enrollment and you're changing, so that you can kind of do some calculations as to whether or not that's going to be what we call an impediment to you seeking care down the line. You know, like I said, have seen people where, you know, like 1 year everything was fine, and then the next year, all of a sudden, the copays are, like I said, if it's a $60 copay, $60, $70 copay, and a doc, you need to see that doc every 2 months. It can add up over the course of a year. So just like for you to be aware of that. So, and that's one of the reasons why you have to be aware of the open enrollment period, because you want to be thinking ahead of time whenever you're going in, so you can compare, yet again, the deductibles, how much you got to pay overall, or how much you pay before the insurance kicks in. What the premiums are, and that's the monthly payment, co-pays, and also provider networks. Is the doctor that you're seeing, make sure that they're accepting that insurance that you're getting, because that's another big one. Because if not, then you maybe make your coverage may be different if you go see that same doctor if you change insurance. So always make sure that's covered as well. These are because this impacts the cost for accessing your healthcare system or your healthcare partners. You may have to change docs if you change insurances. So okay, so that's one thing. So now, just want to talk a little bit about, just kind of a real quick, brief history of insurance in the United States of America. Because remember, we actually have a unique. I know a lot of people complain about, insurance in America, and say, the healthcare system is broken. So one of the things, I took a class in this years ago, and one of the things the professor kind of let us know is that, America doesn't really have a health care system. Okay, there are healthcare systems within America. So stuff like the VA. The VA is a system that's closed. You go there. Like I said, they communicate with each other. They kind of oversee kind of the cost of care. You got to get authorization to go outside of that system or that network. Kaiser is another, is a system. So it's a system. So these systems are in America, but America in general does not really have a healthcare system. There's healthcare, there's insurers, third-party payers, there are, different hospitals, different doctors. But not that those people are overall connected. Okay, so that's one thing to think about. But but like in a lot of places in the world, sometimes they don't have insurance at all. Some people have comprehensive coverage. So like you go to Canada, people in the United Kingdom. If you're a citizen, you get your little card, you can go in, and like I said, of course, it might be a little long wait, but everything will be covered. You just pay through your taxes. But some other places, there are places where literally you gotta, your loved one comes in, somebody's got a handout. They want they want a bill in there. So it's important to know about those differences. But a brief history of healthcare in the United States. So what we call early 1900s, probably before the 1920s. Medical care wasn't costly, but a lot of the care was out of pocket. So you kind of run down to watching a Western, and they have to go find a doc. And then they have to pay the doc, that comes in and, sees whether or not it's cholera or whatever's going on there. But you paid out of pocket, or like I said, maybe you had I don't know, maybe you had a ham. like say you might get traded for a ham. But that's something that was an option back then. Then of course, like I said, we get you get hospitals, and rising costs had I guess these Blue Cross plans. They offered some prepaid hospital coverage. And then I think in the 40s and 60s, you get employer-based insurance due to wage controls in I think it was World War II. And employers basically kind of offered health benefits instead of higher wages. So, okay, hey, I'm company A, like I said, I'm trying to keep my wages at $1.50 an hour. So I can't go up from that, but hey, why don't I help cover your healthcare cost? And so, like I said, you start getting some employers in this healthcare space a little bit. Then 1965, we get Medicare, Medicaid, designed to protect older adults and disabled or low income families. So that's about in the 60s. And then like the 80s, 1980s to 2000s, you get a rapid rise in cost, a lot of uninsured Americans, and denial of coverage due to pre-existing conditions. So at one point in time, if you were not covered, say you were a 25-year-old guy, guy or gal out there, and you developed, diabetes, and then you're like, oh, I need some insurance. Well, you go to apply for insurance, and they might say, hey, we'll cover you for everything else, but anything due to that diabetes, and we're not covering that. Okay, so that became a little bit of an issue because you know, like I said, they could deny coverage. Um, so that was the issue. So then you come up with what we got. You know, a lot of these issues led to the formation of the Affordable Care Act, and a lot of that was, like I said, a lot of uninsured people out there. There were people with rising premiums and deductibles that were going on, people being denied coverage for pre-existing conditions, and medical bankruptcy. People were going bankrupt off of medical care, and there's not great coverage, coordination of care over there. So the Affordable Care Act was ushered in, and it was ushered in order to expand coverage, improve protections, reduce costs, and encourage some preventive care. So that's what's the goal for the Affordable Care Act. So then, of course, like anything else, there's always pros and cons, and of course, that's what we're, you know, politically. That's a political battleground even today. And of course, some people saying it's the greatest thing ever, other people saying it's the worst thing ever, and of course, like always, there's always something in the middle, right? So, you know, some of the pros were that, you know, it expanded access to insurance through subsidies. So the government helped pay some of the premiums to that for people uh, that qualified or was felt that they couldn't afford those. So that, you know, so if you were one of those people, hey, life was good, right? It covered pre-existing conditions without penalty. So like I said, if you had that diabetes, you could get that covered. Whereas before, like I said, insurance might not cover you at all. Okay. Eliminated lifetime caps and limit annual caps on how much insurance would pay. Offered free preventative services, allowed young adults to stay on on their parents' plan until the age of 26. Okay, so that could be viewed as a positive, I guess. Expanded Medicaid in a lot of states that participated. Improved transparency of insurance plans. So a lot of the hidden, you know, it's insurance. So it's insurance is a company. So of course they would sometimes you would have insurance, but it might not cover this or might not cover that. So it was designed to improve transparency and encourage preventative and primary care in order with a goal of reducing hospitalizations. Some of the cons that have been listed out are premiums remain high for some middle income families. And I would say, as a person who was on that, I would agree because I remember my premiums going up every year when I was doing independent contract work. Premiums going up every year, and at some point in time, I went and got a job in order to help provide insurance companies because it was pretty pricey. And I think, you know, you were seeing that now. Yet again, that's one of the issues that's going on, that the premiums continue to rise there. Okay. Other cons, deductibles can be large even with subsidies. So like I said, you might get some, you know, you qualify for a subsidy, but you're still subsidy for the premiums, but you still have significant deductibles, kind of like we said before. So that's where, you know, knowing what product you have and, like I said, understanding those additional costs on top of having the insurance can be important. Then some of the insurers left the marketplace, which, you know, like I said, of course, the more people you have participating in this marketplace, the more options you have. And of course, you know, theory is that there should be more competition to keep some of the premiums low. But what they found was that, especially earlier on, the networks could be pretty limited because a lot of the insurers would leave the marketplace, leaving you with fewer choices. There could be limited plan networks in certain regions. Yet again, another thing that you know, I experienced where I was offered a product that I thought was reasonable, and come to find out that I could only use this in certain hospitals in a certain area. So if you travel outside that particular area, you weren't covered at all, not, you know, like at all. So so that was going on as well. There was increased administrative complexity. You know, anytime you got it's the government, so they like administrative complexity. So so that got a little complex. So like I said, that's one of the cons as well. And of course, political instability around the law created a lot of confusion. So like I said, you know, one party would get in, and like I said, maybe some things would be going on. Another party comes in, and of course, they want to take some things out, and so that went back and forth. And yet again, as we just kind of saw, where, you know, people can be pretty passionate about their side of what's going on there. Okay, so so that's kind of giving you a little bit of background about, you know, history of health insurance, the role of open enrollment and getting your stuff covered. And then, of course, you know, the Affordable Care Act, which, you know, kind of really was a huge deal in the United States. So was and still is a huge deal in the United States of America. So how is healthcare financed in the United States of America? So, because I think a lot of people don't really think about this. You develop diabetes, you develop high blood pressure, you get in a car accident. How is that paid for? It's a great thing. So, and we kind of covered a little bit about it. So, the private insurance, whether that's employer-based or individual plans, okay. There are the government programs, that's Medicare, Medicaid, VA. There's out-of-pocket spending, and then there's charity or safety net programs. Okay, um, so 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 we have a multi-payer system, if you want to call it system, you know, in the United States of America. So if you have an insurance card, and it's a private insurance card, what happens is that that private insurance, so like yet again, Blue Cross Blue Shield, will negotiate with a hospital A. They'll negotiate with, private clinic A. And honestly, they'll have contracts with each one of these practices that decide to contract with them. Each one of these hospitals that decides to contract with them. And the way that works is that, you know, kind of like I said, you'll take your card to that hospital or that practice, and they'll kind of pay based off what they've kind of privately negotiated, which of course you won't really know. Like I said, nobody else knows. The government programs, Medicare and Medicaid, usually a little bit more transparent. So like I said, you can actually look up some of the reimbursement that they give, and then of course out of pocket, which a lot of people don't really in the U.S. Currently don't really think about, and that is the fact that you can actually go to a doctor's office and say, hey, I have diabetes. I want it managed. How much will you charge me? And in the past, it was kind of hard because sometimes there are rules around, um, you know, doing cash arrangements. But typically, it's because some legal confusion. Because, like I said, if it's Medicare, you can't. There are a lot of restrictions on that. If it's private insurance, it's kind of hard to, like, if the patient goes and tries to get, maybe they pay you $50, but then they turn around and try to get that money back from insurance. Like I said, there's a lot of contract issues that are there. But if you're a person that does not have insurance, you can actually go to a primary care doc's office and say, hey, I don't have insurance. I'm willing to pay cash. How much will you charge me to see you? And like I said, a lot of an increasing number of practices actually have what they call a cash price. So they'll tell you approximately how much that you can, how much it costs to come in and be seen, and then they'll follow-up visit. Usually, a lot of times there'll be an initial visit, then your follow-up visits are a lot less. And then there are other programs, what we call direct care, and we'll talk about direct care stuff next time, where you can do that as well. So we'll talk about a little bit more about this the next week, because it's a little, like I said, a lot of stuff is pretty complex there. Okay. So a lot of times, and like I said, these providers, whether it's, the private insurers and stuff of the nature, they negotiate contracts with the insurers, and these contracts determine, what services cost, how much the insurers will pay, and what's the patient's responsibility, which is copay, co-insurance, and deductibles. Okay. Okay. So that's kind of a broad view of the insurance background and how that piece works. I think one of the things that people don't understand about how this financing works is that the bill you receive. So a lot of people will get a bill. So you go to the hospital ER, you get a bill. The hospital bed, staying in the bed is $5,000 a day. The first doc you saw was, like $1,500. The aspirin was $75. And so you'll get this price and you're like, what the heck is going on there? But they don't understand that, like I said, yes, that charge is there, but the amount that it actually costs, or the amount that the provider or insurance gets paid, is almost never anywhere close to what this charge is. So that's where a lot of people are like, oh my God, I can't believe these bills, whatever. It's because that bill that you receive is completely marked up, and it is literally part of how things are negotiated in the healthcare world. Like I said, if you see me, I'm probably going to, yeah, I'll probably write a, you know, $500 for the 15 minutes or whatever, something crazy. But you may get back $50, $25, depending on what's going on there. And it depends upon what's going on there. So that makes it very confusing for people, because sometimes people are trying to understand, why a clinician or why practice would drop an insurance. Well, you're charging all this money. Why are you trying to? Well, in part of this negotiation, sometimes what happens is that yes, you paid your premium to this insurance company. Okay. And when you, and so, okay, we're just going to use me because it's a lot easier to do it. Okay. So you have an insurance card, and, I am, you come to see Dr. Brown because Dr. Brown is on the list of doctors for insurance company A. Okay. So you got insurance company A's card, you pay premiums to the insurance company. And so Dr. Brown is on the list of docs that's on the insurance company A. Okay. And maybe you've been seeing Dr. Brown for 5 years. And then all of a sudden, you're number 6, Dr. Brown drops the insurance company. And a lot of people are like, well, that doesn't make sense. Why would you do that? Because yes, you may be still paying the same or even more money. But sometimes what the insurance company does is it says, you know what, I'm not going to pay you. I'm not going to pay Dr. Brown what I was paying Dr. Brown before. I'm going to drop the price. Well, like I said, if I'm Dr. Brown, I got to practice. I got to, this sort of stuff I got to do. So I can't, sometimes, a lot of times, some of the initial drop, the practice may absorb, but sometimes it gets to a point that, hey, it doesn't make sense to be seeing someone if the insurance company will not release enough of the funds for that particular practice or that particular clinician. So that's where a lot of that stuff comes from, where, you're seeing someone and then all of a sudden the practice drops the insurance company, or maybe you've seen on news where a hospital system will say, hey, we're not going to see people with this particular insurance company next year. And a lot of times this negotiation is going on behind the scenes. And you may look at it and you might be like, well, dang, I'm paying more money. Why am I not being able to see people do that? And that's a lot of times what's going on there, because because in the United States, we have this third party payer where you're paying money to them. They're negotiating how much of that they're going to release to the doctor, the hospital, and the two people, so the hospital and insurance, don't really control, or it can be difficult to control how much of that money will be released by the insurance company. So this is just to give you a little bit of background around why insurance is so complex. And I'm kind of running at the end of this show here, but I just kind of wanted to give you some basics around what's going on there. Now, next week, we're going to cover, what can you do if your insurance is super high? You just get to the point you can't afford insurance. What sort of options are out there for people to look at different ways to cover themselves for healthcare expenditures. So there'll be things like, there's direct primary care, cash clinics, shared payment programs. So those sort of things that are out there. And so we'll cover that a little bit more in next week. But I wanted to give a little bit of information about how insurance operates in the first place, and to kind of get you set before we go into the next topic, or a little bit more in depth in the next topic next week. Okay, so hopefully this was helpful, because I really hope this is helpful, because I think it's complex, but of course we need to understand that in order to make sure we're getting things covered. Okay, so outside of that, thank you all for tuning in and for listening to me. We will be back next week to talk a little bit more about what to do if you either can't afford that insurance, or if you lose the insurance and you're looking for ways to keep yourself healthy and covered without any interruptions. All right. Thanks for tuning in.
All right. Was the Dr. Brown, here WVOE 1590. Stay tuned. We'd like to thank him for calling in with all that good information. Stay tuned here at WVOE as your host, Mr. Lopez.